with no further ado, I would love to, give it to Dr. Bodne and teach us about why you feel coning is going to be the path of the future.
So what I figured is this. I mean, I could give you all the talks and the numbers and the slides and everything, which if when I'm on the receiving end of that, I last about 10 minutes about this time of the day. So I was going to actually just show you how I make the sausage essentially. So I've got a few cases, some findings, and kind of just show you essentially how I read these to give you a sense of why, so that the question is, why is this going to be better than mammo? I mean, I don't use the R word. I will not use the R word because that requires a crystal ball to know whether this will be the next mammogram. I mean, it's probably going to do that for MR for a lot of indications. But so basically, the way I read these, I start to make sure everything lines up. So you got to make sure this is your only landmark really that you've got is the nipple. So you make sure the nipple lines up. Then I come down here and I do a thicker section. What I found for calcifications is that's the best for calcifications. And so what I'll do then is come through in the 3D MIP images, and I basically remove the skin, which you'll see as soon as okay, so it does that automatically. And what this shows, this is a great overview. You see some vessels, you get a sense of what the parenchyma looks like, and you can see calcifications very well. And the other thing that this helps, I mean, there's a lymph node, but you can see also not only calcifications, but you get a sense of distribution. And these are, people have asked, can you see calcifications? Well, I would say you actually see them a lot easier than you do on what she came back for. Let me get this one blown up here, if I can get that to happen. And so she came back for a diagnostic evaluation of these calcifications. See if I can move this around, actually get these back into view. There we go. So here's your calcifications on the CT on this right screen. Okay. And you're going to have to trust me on this one. There's the calcifications on a mammogram. We play with that. We can do whatever we want. We can manipulate that in many different ways. But I'm going to tell you, we can magnify it. We can do everything you want.
Yeah.
They're there. But I would say, for me, for my eye, maybe it's just my old eyes, I see them better on the CT. Now the question is, do you need to do the mammogram for the characterization? I think the jury's still out on that one. That may still be a good indication, definitely an indication for mammo, but this is what I've been finding is you see the calcifications more easily on CT. I mean, they're there. I promise you they're there. And I'll show you the other view is, where are they going to be? I think they're up in here. She had these marked and then they went away. But they are up in, it's not them, it's up here. And so, the question is, what'll be the workflow for that? It may be that you do the CT to find them, the mammogram to characterize them until we get to the point, because what you're basically doing with a mag view is you need to boost your MAS. You need to change the variable so when you magnify it, you decrease the noise. And so, you just, because this is a true 3D image, you can see how you can see them better on the CT. And then what I do when I read after that, I'll come back, I go to the coronal with the thicker section. Thicker sections are better for calcifications because you get less noise. And so I'll come through, blow these up a little bit, and then I'll just kind of scroll through this to get a sense. You can see some dermal calcifications, which is nice because on mammo, a lot of times we call those back for diagnostic workup. And what ends up happening is, you bring them back, you radiate them, and you find it together in the skin. Well, I can tell you that right off the bat. So you're not going to call them back for that indication. And you kind of scroll through, get a sense, okay. And the other thing that I've been asked is, can you see the axilla? Well, there's a pectoral muscle. So you can see level 1 nodes. So you're not really missing much. And you lose, I mean, you're really probably not going to see level 2 nodes, which is plus minus on a mammogram. But you can see there's a tail, there's your pectoral muscle. You're up in the axilla here, so you can see level 1 nodes. So there's not a question of that. You can see some nodes here as well. So calcifications, yes. Axilla, yes. Then the advantage. I come through and I'll read. Then I bring this one down a little bit. I do blow this up. I will do, let me get over here. Basically read an inverted image first. That's a good view for some calcs. But get sort of an overview. Are there any masses or anything? You can see the axillary nodes again. And then come back in 6 millimeter thick. You still can see calcifications. Well, there's a clearly benign calc, round. And then the calcs that we were looking at and questioning are, not that one. That was the one we could see on the mammogram of those. And so, then you kind of go back to basics. And the question is, do you need to do anything else? For me, a lot of times I'll go from this straight to biopsy because these are, they're either monomorphic or pleomorphic, right? That's your choices. These are different shapes. That makes them pleomorphic. So I don't know what doing a diagnostic is going to change, because once I see that, we've gone straight to biopsy, and these come back as one of two things. They're going to be a cancer, they're going to be fibrocystic disease, or one of the variants of that is what they come back as. That's what our experience has been when they've gone to biopsy. Excuse me. So you can see them, you get a pretty good sense. You can blow them up. The problem is like I said, you get a sense that these are mildly pleomorphic or pleomorphic without needing to go to anything else. I don't know. Some radiologists are going to want to characterize those better. It's just a matter of where you are on the learning curve. But I feel pretty comfortable with saying these need to be biopsied. These are pleomorphic. So that was this case. I don't know if y'all have any questions about.
Yeah. So is this just to confirm? This is a scan without contrast. Is that correct?
Correct. Correct.
Would the calcs have any different characteristics if there's contrast, IV contrast used?
There wouldn't be. They would be the same, and you would know about that on the pre, but you could also tell because there's a little bit difference in attenuation. And one of the nice things also, being CT, is you can also, if you wanted to, you could check the attenuation, and you get a sense of what glandular tissue, what fat looks like. So you get that advantage as well. So you can tell, and sometimes you might get questionable findings. Is it real? Is it not? And if you can triangulate with, you can triangulate with this, but if it's still a question, I'll go through and I'll measure attenuation. If it's the same as glandular, I'll pass. And it's going to be, that's usually just a summation artifact or something of that nature. But what'll happen with contrast, so the advantage of contrast, and this is really regardless of the density, because we had a case where it was a B tissue density. This one's probably BC in that general area for density. And you get it really, if you want to get a sense of density, I usually go to a thinner section just to get a sense. And this is probably more like a B density. But I've had a case where the lady had B density. She would never have found what she had found. We gave her contrast, and it was literally in a pocket, like one of the small pockets of dense tissue. She had an enhancing 1 centimeter cancer. So that would have gone forever and ever. She never would have qualified for supplemental imaging because she's not a C or D density. So the question is, how long is it sitting there? We may never have found it, but we gave contrast because what I noticed was a subtle difference in attenuation. And you can do a lot. You can play with the data like you can with CT. You can play with the window and level. So you can do pretty much anything you want to do. Like I said, one of the things we talked about for for radiation is you can play. Really, it's going to be more this one, I think, for radiation oncology, because you can take these views and you can. Where's the rotation view? You can definitely rotate along this plane, but there's a way to set it up so you can pretty much rotate in 3 planes. I have not played with that for, it's one of those things I usually just rotate in this plane. But from radiation planning standpoint, you can easily do this and you get a sense of, okay, what's going on. You can imagine if you had, let's say, a cancer in here, you could easily target it. But yeah, these are done without contrast.
Great. And you mentioned the slice thickness, being thicker, being able to see the calcs or characterize the calcs better. What is the slice thickness it's acquired on? Is it like a 1.25 or 2.5 cm?
I want to say, I think it is I want to say it's a 1.2, if I'm not mistaken. I'd have to go back and look at the numbers, but it's thin section. Might even be smaller than that.
Okay, because I was looking at the when you're pulling out the lymph nodes, they're actually pretty well visualized, and I wonder how comfortable you guys feel about characterizing them as opposed to just or in addition to ultrasound, because I could see like the fatty hilum and having it look like a more of the morphology of a normal lymph node versus something that's more solid, consistent with like a met.
I agree with you. I think if they're benign, they're going to be clearly benign. But I've seen if there's any question, especially if I've got a suspicious finding and it looks like it's going to be a cancer, they're going to come back for an ultrasound anyway, because then you'll find out which one, how many lesions you're going to go after if you go after them with ultrasound, which is always easier to biopsy. And then I'm always, every time I mean, my protocol for ultrasound, if they come back for ultrasound, 100% of the time they're getting axillary scanned. I do that regardless of whether I see it on a mammogram or not. I'm still going to do an axillary ultrasound. It's just my protocol. Maybe I'm a little bit OCD about it, but 100% of my ultrasounds get an axillary scan. And I mean, if it's one finding, I'll do that quadrant and axilla. If it's multiple, I may do the, whole breast and axilla, but they're always getting axilla if they go to ultrasound. But to answer your question, yes, the answer is yeah. I mean, you can see that one those look clearly benign.
Yep.
I mean,
Like
so
fatty
you can see
highlight
those.
there.
Yeah.
So that's why I was seeing those, and I was like, oh, they look like you could see the morphology. If that would help sway you one way or another to call it more likely to be of concern or not.
I mean, if there's nothing else, then I would make those benign. Where that is helpful are intramammary nodes, because a lot of times you see it and you're going to call it back from a routine. What we currently do, our current workflow is you'll see a mass. You may or may not see the fatty hilus. I've been told by many radiologists, I just don't trust it. I don't trust that they're going to come back for an ultrasound. So they come back for an ultrasound that's benign. I think with CT, because you can play with the slice thickness, you can do the same feature and you'll hopefully avoid many callbacks for that.
Okay.
Let's see. Then there was another case we have. Need to keep those kind of hidden, so I don't know if you want to close your eyes or not.
I think we're all over 18 now. I
Let's
just turned
see.
18. Yeah, so I just turned 18 like yesterday.
This is a definite advantage of, let me get those off of there. Where's the patient data? All right. So we don't know who this is. So we'll go through the same whole process. But this is one of the really nice features of 3D data. Okay. And so this is something that'll be solved with PACS. This is basically just my protocol because I'm reading from the server. Okay, so because I'm reading from their server, I have to go through and do this, but all this will be automated when we get some more PACS vendors doing this. So basically everything lines up, go through, do the whole thing. Let me get this out of here because that's not going to be relevant here. Let me blow this one back up. So go through the same whole process. She's got some arterial calcifications that you see very well. I mean, there's not even any questions about that. A little bit less so, but she's got some some vascular calcifications. Go through, do the whole process. Let's see, maybe not. I think we got the skin on okay. And scroll through, same thing. You can see some vessels. This one is contrast. I believe this is contrast. You can see the vessels look like they enhance. You see the axilla, there's really nothing going on. Going through, do the intersection. And I promise you that the payoff will be worth it. So just kind of bear with me on this one. The nice thing is, on a mammogram, you have to usually do the implant displaced fuse. No need for that. I mean, you see the tissue around it without any problem, right? Same thing. This one they had to reload. I don't know why we got those. Disregard the lines. That's I think that was just from reloading. I think this one they had to dig out of the files. But anyhow, but you see how the tissues around is entirely normal. This one is basically, I'll just spot you that it's normal. And then here's the cool thing about what we were able to do 100% of the time. I mean, literally 100% of the time. You see it? Implant rupture.
Yeah, the wrinkling of the skin, right?
No. I mean, so you see this white line in there?
Yeah,
That's
the
what
skin of the implant. It's like
right,
pulled in.
Well, I mean, no, this is literally, you can see, no, this is the implant.
Right. The
Yeah.
lining, not the skin. The lining of the implant.
Right. Yeah, I mean, it's funny, we have, there's so many different names we have for an implant rupture. The bottom line is this: if you see silicone on both sides of the lining there, it's ruptured. And I mean, we do this 100% of the time. I know with the plastics folks, they're saying every 2 years with MRI. I'm saying that you will never need an MRI to evaluate implants again. I mean, it's just that's every time we see an implant, it's like that. I've seen keyhole signs and I've seen linguini signs, but I mean, it's close to lunch, so I don't know if you want to talk about linguini, but anyway, but it's the same thing. So implants we evaluate all the time. So there's no, like I said, there's no need for them to get the extra study of an MRI. This is routine. A lot of times she was a little bit smaller breasted, so a lot of times we're also seeing the tissue behind the implant and the ribs, which is something you're never going to see short of an MR. So really, it's either this or MR. And I wish I had a case actually now that I think about it, but I'll show you one on our next go around. I may have one, but implant rupture is a fairly common thing. I mean, when we see it, it jumps out at you. So I don't know if there's any questions on that one.
So is the silicone maintaining its shape because of the fibrous capsule basically it's formed around?
Yes. Yes. I believe that's usually the case. I mean, it's one of those things where I guess that's more of a question for, for plastics folks, but that's my understanding of it anyway. And we did also have a case, I think I've got it in here somewhere. I have to dig it up, but we do have, actually another case, because the other thing you obviously look for with implants is whether they've got, the peri-implant fluid. Let me see if they loaded this one for me. We actually did have a case. What was her first name? Yep. Okay, there we go. Let me remove from patient data. Now that I know where the button is, we do that. So she had on a different case, and this is kind of what you see. So you can see the tissue between the implant and the ribs. Okay, but this one has some peri-implant fluid. Let me see if I can get that one. And you can kind of see, because here's the implant, but that's actually outside the lining. That's some peri-implant fluid. So she actually had that aspirated. It turned out to be thankfully benign. But you could see one of the things that's was interesting about this particular lady, interesting and not necessarily a good way, but you can see there's some suggestion of some enhancement of the lining compared to the pre-contrast. All right. And so that was the reason I raised the question, and they went ahead and they did ultrasound guided aspiration and turned out to be sterile fluid. But that's one of the things that we always look for. I think I've seen in 30 years, maybe 5 cases of the peri-implant lymphoma that they'll get. But I know that's one of the things we always talk about. But you can see pretty much, this is, I always tell our technologists, you've got a scan that I'm not going to call them back. If you see, basically, if you show me 3 things, I'm not going to call them back. One is, and I've had a friend that died from metastatic disease from a missed cancer in the inframammary fold. You always see that. So, I mean, that's when you almost have to be intentional to miss. And a lot of it's because gravity basically pulls it out, as opposed to the technologist continuously manipulating that part of the breast, and then you end up losing the top of the breast. So you see that. If you show me the ribs, and if you show me the axilla, like I showed you on the other one, those are technically adequate. And then no motion, obviously you don't have motion, but you can pretty much see the axilla. So sometimes you get right at it, but you can see them. So as long as they're showing me that, those are technically adequate studies. And so your coverage is comparable to a mammogram, but you don't have to do anything because of the silicone, because, if I had a question, which you never do because you pretty much got a 3D data set, you don't have to do implant displaced views. That saves you on radiation. That saves you on extra compression on the patient. And then, of course, like I said, you can always evaluate the implant structure integrity as well. Let's see if I can find an interesting case for you here. I don't know if y'all have any questions about. It's just, like I said, just really more for the fluid.
When we were seeing about the last 2 patients that had implant rupture, I was curious as to how common it was. And I was just doing some basic literature searches, and it sounds like about 10% of patients that have had implants over a few years will start having implants. And apparently the FDA updated their recommendations or the guidelines for the inserts of implants to now put in their recommendation for regular screening, specifically with MRI. But I was just wondering if that's something that has been studied or you guys are looking at doing, as coming out with a publication about the utility of breast CT for implant screening, if that could be an alternative modality.
I'd need to talk to some of the folks. I know Roger, we've done some papers and some presentations showing implants. I don't know that I'd have to go back and ask. A lot of the data, a lot of the literature is out of China. They've done probably about 150,000 exams. The problem is, because of the politics, sometimes it's easier than other times to get the data out. But we've got connections. So, Koning having a lot of connections into China, we should be able to get that data. And I know a lot of the papers are out of there. But right now, because I'm not an academic center, all I can give you is, my just experience has been that you're not going to miss it. You change the window and level. I've never missed. Now I'm going to jinx myself. Let me not say that. To date, I have not overlooked an implant rupture. Now, of course, the one I read this afternoon, who knows? But hopefully not.
Master equipment, do you guys know if a implant is ruptured and it's not cosmetically different, is there generally a recommendation to replace it, or is it just patients losing it?
Yeah, that I don't know. I mean, that's more of a plastics question. I don't know, because I know they're saying they recommend that they be evaluated. I thought it was biannually, but if it's annually, then that's even going to more likely break the bank, because if you've got to do an MR on these patients every year,
Yep.
that's expensive. And what that's going to do is it's going to gum up the system, because I don't see hospitals buying more magnets just to cover those patients.
Yep.
So what's going to do is your extended disease evaluation and everything else that we like to do with MRI is going to be put on, it's going to be put off to the next day and the next day and the next day. And it's just an MR. I can tell you, if you tell a radiologist that they're going to walk into a day with a full day of diagnostics, biopsies, and screeners, and oh, by the way, you've got 15 MRs to read at the end of the day, I would imagine that there are going to be a lot of 401ks explored the next day. So, unfortunately, you've got to take all these variables into consideration before we make blanket recommendations. MR is great. Don't get me wrong. I love MRI. I think it's a fantastic test. But, there's some question. I saw a case online the other day, and it was they recommended, evaluating everything. The problem was the MR was the most accurate for measurement. They felt they measured a 7-centimeter tumor. She went to mastectomy that found the 0.4-centimeter tumor. The rest of the breast was just reactive enhancement. So the problem is, because of the lack of specificity, I mean, we had a case where you're not seeing as much background enhancement on CT. So the things that do enhance are more often than not significant. All right, this lady, let's see, I think did she have an ultrasound? I thought she had an ultrasound, but her finding is basically, again, just some calcifications. And that's always the question I get. Can you see calcifications? I mean, yes. But, if you need to be more certain. So they pretty much, they stand out. And like I said, do you need to do diagnostic imaging to show those are pleomorphic? I mean, I don't, but like I said, I'm just me. I'm not a benchmark. So, it's one of those things where people will see that and they'll decide as they get, certain points on the learning curve, how you feel about reading that. But it's one of those things, the other question you always get is, how long does it take to read? I mean, I think, to me, this is easier to read than tomosynthesis, which is essentially linear tomography, which, I've been practicing long enough to watch that whole progression. I think linear tomography was the threshold to get us to CT. And once CT took off in every other organ, nobody does linear tomography. I mean, it's rare. You'll rarely do linear tomography. I mean, it just jumps out at you. It's like reading any other mammogram. When radiologists see this, they realize, I mean, I get the same comment. Yeah, I can do that because I've been doing that. Yeah, I've been doing that. There's no findings that I'm seeing on this that's different from mammo. Calcifications, masses, architectural distortion, suspicious of pathologic appearing lymph nodes, skin thickening. We've seen everything. So it's not anything new. It's just, it looks different when you first start seeing them, but you can also do biopsies with this. You can give contrast with this. So now you've added the value of vascular imaging, which, MRI without, I remember hearing lectures back in the early 90s about MRI, and they never made it clinically useful until they realized they've got to give contrast. So MR without contrast is good for implants, and otherwise it's not. So again, this is a case, you can see the mass, fairly significant mass. If there's a question, is that a mass? You could always do, like I said, you can see this is what glandular tissue is. That's significantly higher. So that warrants an ultrasound to see what's going on in there. But you can see there's something because of calcifications. So just an interesting case of that. We don't have a pathology on her yet.
Yeah. So the architecture looks different there. It's like solid, homogeneous.
Right. And if you have, I mean, you can always, change your window. Whoop, let me get that. You can change your window level and you can see, I mean, there's a mass there.
Yeah.
So
Dr. Craig, remember, this week you shared with me that, that ultrasound that doesn't have, it's like that wand and iPad.
Yeah.
Liz, can you put that link? And I'm just wondering, Dr. Bodne, like we're looking into adding ultrasound. And would the butterfly ultrasound, which is really like that the wand and just the iPad, is that something that would also be good for breast imaging for like additional workup? Or is there a reason you need that traditional clunky ultrasound thing?
You do, and the reason is because anything you do in medical imaging, you have to document, and that's not FDA approved, I don't believe,
That
for
was
breast.
gonna be my question. What is
Yeah,
that?
I don't think it is. I think because honestly, listen, the price is fantastic, but it's just I would I mean, I'm kind of jumping into commercialism now. I don't know enough about it, but I haven't seen it, but I would go with the traditional ultrasound. You can get ultrasound units that are pretty well priced. You're going to do enough of them that'll justify the expense of getting one. And all, I mean, to me, you can't run a breast program without ultrasound. I mean,
Yeah.
love it or hate it, it is the workhorse. We need ultrasound because the other thing is if you find something you can biopsy with ultrasound, that is always easier for the patient as well. I mean, breast biopsies on CT and MR are going to be prone, which is a little bit more challenging. Ultrasound supine, it's much easier for the patient. I think it's more cost effective. So I would say on the butterfly, let's just say the jury's still out on that one. How's that sound? Let's see, we got some more.
Is it, do you typically do the ultrasound yourself, or is it their technologist that's doing the ultrasound?
It depends on the technologist. I would say, excuse me, a good technologist is worth their weight in gold. But there are still going to be cases if I'm not clear on what I'm seeing, if I'm not matching, if it's not correlating 100% in my mind, I'll go in and I'll watch them scan. And usually that's enough to inspire because I can kind of guide them where they're going. I usually will use my scanning as a last resort because it's to preserve dignity, to preserve some privacy. I will stand behind the technologist. So I'm watching her scan. So the patient, is feels more comfortable, I think, if you've got that buffer between. So I'm watching the screen. I mean, that's not, I know I'm going in there, but patients may feel more comfortable knowing that you got the female tech in the room. She's doing the scanning, and I'm watching the screen. So that way, I'm not watching where I'm scanning. It's just it's more
Yeah.
it's more the optics of it, if you will. So I do if I need to. I mean, it's rare because I've got great techs. That's really the key. If you've got great techs, I mean, I trust them inherently with what they're doing. They know what I'm looking for, and if there's a question, we'll go back in the room. I still go in the room at least 80 or 90% of the time because I like to watch. Sometimes if it's negative, especially, I'll go in the room because if I'm sending them out, I always tell them, if I'm sending you out with a negative report, I want to be 100%. I won't even accept 99% because if I tell you it's negative, you're not coming back, and if there's something there that I'm not seeing, you're not coming back, and then you'll come back later with bad news. So negative reports, negative scans that are shown to me, I'll go back in just to confirm, make sure. Young patients, I will because again, they're not coming back for routine screening. So there's certain things, but it really comes down to how well you trust your tech and how good they are. If they're good, you still you may go and scan, but I don't. It's rare that I scan on my own. If that answers the question, hopefully.
So logistically, for workflow, for instance, does that mean then that you could also be able to do ultrasound with a radiologist remote? For instance, if we get the ultrasound in the mobile unit and they're scanning it, do you need it real time, or is it like a breast CT, just acquire the images and you review it post?
You can do that remotely. The way that works, and it has to do with your PACS vendor. You can do a cine loop, and so if the technologist, and we do that fairly routinely with our site in Tifton, Georgia, is they'll do the ultrasound and they put we probably occupy several gigs of data with cine loops, but they will go through and they're very thorough. If they see something, they will scan pretty much around that whole area. They'll do quadrants. They'll do whatever. They figure we're looking at a certain area because they know on ultrasound, always show me the axilla, show me the quadrant if there's a finding. So we get a lot of cine. So you can do cine loops, which is more of a feature of your PAC system, and then it can be done remotely.
Dr. Bodne, when you get a sec, we also wanted to just ask about a case that we just had.
Sure.
The question is more related to the recommendation rather than the actual image, but it may be helpful for us to see what a D-density breast looks like on non-contrast as well.
Sure.
But essentially we had this lady, because you gave her
Sure.
BI-RADS 3, but she's a D-density breast. And when we spoke about it as a group, you were recommending that if you're D-density or even C-density, you likely need contrast to really see what's going on. And so your recommendation was for a CT in 6 months. We were just wondering if when Dr. Nguyen calls her, should she recommend that she gets a CT with contrast in 6 months? Because we won't have that option for her.
So this is the way I word that because of that particular reason. Do I recommend? Yes, I would say 'cause this is a D density. You can see I can bring this down as thin as you want. You're never going to see areas that are a lot of fat interspersed. That's purely glandular and tissue that adds to the density. So, but do I recommend contrast? I mean, I think that is a more of a blanket recommendation. I wouldn't make this a BI-RADS 0 because of density. I know some radiologists have done that. The problem is if you make all of your C and D densities BI-RADS 0, your tracking for audits is terrible. So, it's just a matter of how you word it. So I would say, yes, I would recommend it. But the problem is if I put in there that I recommend it and you don't do it and there's something in there, we're all showing up in court. It's the way it works. So what I would say is I may say, because of density suggests that or the current recommendations or guidelines are supplemental screening, one of which may be contrasted imaging, such and such. Because the problem is right now, if every report that's a density like this says recommend vascular imaging such as MRI and you don't do an MRI, I mean, that's, the patient may not be able to get an MRI and then you're kind of stuck. This at least gives that option, but no, but the BI-RADS is based on the findings. It's not based on the supplemental things like that. So that's one. So I would make it a BI-RADS 3 because the calcifications, let me see where I had those. We're on 148. Let me do that. And that's the other nice thing is for diagnostic purposes is I always put in my reports as well where on the image it is. So I put 148. So I'm actually looking at down in this left corner. Well, I guess I can take that out. And so based on that, right, so I can see this is coronal slice 148. That's what I usually use my recommendation. There they are. So for radiologists that have the days of diagnostic imaging where you're, spending 5-10 minutes to find things, you can find that in about a minute. If you've got the reports, the coronal image, and I'm telling you it's 10 o'clock position, 11 o'clock position, there are the calcs. So it really makes that part of our lives easier. Those that are on the receiving end of diagnostics where the annotations may not have held and you're wondering what's going on. So this way at least, and then you can triangulate. So I can tell you there's the calcifications. The reason I made these a 3, they look like they're trying to form a mass, although you can't see anything because of the density. And they look more like maybe a degenerating fibroadenoma. So these are a little bit more amorphous. And so that's why I made her a 3. You can see on this one, probably get a little bit better sense that it's trying to establish a mass. So if it's, rule of thumb usually is if it looks like it's forming a mass, give it a chance to see what it's going to do. So I'll bring them back in 6 months. But the answer to that is, I mean, yes, but if I put on all the CD densities, recommend contrast, what happens? I mean, what happens to y'all's patients?
When we had our discussion on Friday, my understanding, or I guess this is a couple weeks ago now, my understanding was that the non-contrast scan without a possibility of ultrasound and without contrast was only for screening in women with A or B and maybe C density breasts that haven't had really like any prior imaging showing that they had D density breasts.
Right.
So I'm just trying to think now, in this case, this lady has identified D density breast.
Right.
We wouldn't necessarily tell her, because is there concern that if she just gets a non-contrast scan, you could be missing something, not just this finding, but something else that didn't even show up in this initial scan?
So this is one of the little tricks that we learn. Just takes a little bit of time, but you see how you can change the density. And what I've found, just kind of tracking, again, this is nothing in the literature. This is just personal experience. If the density goes away homogeneously, it's unlikely to have something in there. Like I said, that needs to be borne out with the literature. But you see how you can still, even with very dense breasts, how you can do that. I mean, there are little tricks that you'll learn along the way. And I mean, the thing that stands out better is the calcifications. So, that's a different attenuation or different density. But everything else is, I mean, if you gave contrast, yeah, you might see non-mass enhancement, you might see small things, but is it Useless? No, I don't want to say it's useless. I think you can still, there's a lot of other ways to play with the data. You know, you can change the window and level, you can do inversion, right? And that even, that helps some of these things stand out even better. You see the calcification stand out a lot better with an inverted image. You can do, we've got edge enhancement, right? So there's a lot of things you can do with true 3D data that you can't do with other studies, even with very dense breast tissue like this. So I guess the first answer I would say is, no, I don't think this is useless in any density. I think it's going to be more challenging, but it's not useless. So it's better than them not getting anything. So let's say this lady said, I don't really care what you say. I'm not getting a mammogram and, I don't want contrast. Well, I would hate to turn her away from, if that turns out to be bad, I would hate to have turned her away. So that's the thing is you make the appropriate compromises when necessary. Yes, it would be ideal to give her contrast, but I would never turn somebody away if this is all they're willing to do.
Yeah.
Right. That makes sense. I guess I'm just like, because we don't want to make that compromise for them without having a discussion with them. So we
Right,
want
right.
them to be the one making that compromise. And of course, if they're saying I will not be able to get anything else, I'm refused to get anything else. I think that's different. But I'm just wondering.
What if we took a
Yeah.
step back and said that, a lot of patients don't have access to breast CT, and this was seen on a mammogram? What would have been the next recommendation at that point? You saw something that was a shadow of it, and there's dense breast, but you wanted to further categorize, and we did not have access to breast CT. Would be sending them for ultrasound at that point in 6 months, or would it be a repeat mammo, or would it be?
So the way, all right, so let's say this was a mammo. So what we would see is the calcifications. They would go, assuming I could see the calcifications, you would call them back for a diagnostic mammogram.
Okay.
You would get them, you'd characterize them as a BI-RADS3. You would say, C or D density. You have the little line. Everybody has some kind of predetermined line that they put in about dense breast. In Georgia, we've got a full paragraph that, they got to read through, but basically it all says the same thing. You have dense breast, you would benefit from vascular imaging, i.e. CT, MRI, anything vascular, or supplemental screening with ABIS is the other. And ultrasound would be good in a case like this as supplemental screening. With that, there's two options, but the option that's more acceptable is the whole breast ultrasound. You can do handheld. Handheld is 100% dependent upon the technologist because those are never overseen by the radiologist. That is basically the technologist does it and then they send it in. I have questions about that because that is so operator dependent and they've got automated machines. There's a new one coming out of San Francisco called iSonos we looked at the other day. That's interesting. I'm still evaluating it, so I can't say one way or the other. I was impressed with it, but that would be the other option is you might go to ultrasound, but you'd have to do ABIS, not a handheld. So that would be a different service, which I don't know. I don't know the availability in California. I know in Georgia, there's probably 3 sites in the entire state that do it, and I read at 2 of them. So, if Hoag has it, it's ABIS, the automated breast ultrasound. So that would be the other recommendation. So you'd send them from this. If there's a mammogram, diagnostic, BI-RADS3. By the way, you need supplemental screening, and then you just have to figure out. The thing that's so frustrating has always been for me is that we beat our chest about breast tissue density. You got to do something else. What else are you going to do? We have nothing to offer you. What are you really going to send the woman out and say? We're concerned that we might be missing a cancer, but sorry, Charlie. It just doesn't sit well for me. That borders on unethical. I have a problem with that.
I think we're at our time and I really appreciate, the dialogue and I'm hoping to do this at least once a month.
As we move forward and as you get more cases, if you have a case either with questions or an interesting case, and then I get the information so that way I'm prepared to answer. Because if I can come in at least preloaded with what we're looking at, then that would be awesome. And yeah, send it out to I saw the invite on LinkedIn. I think we're starting to get some more general interest and some curiosity because people are finally realizing, okay, this is not it's not the boogeyman. It's not hiding under the bed to eat your liver or something. It's
Yeah.
this is actually I think this is we're looking at the future of breast imaging, but it'll take time. I'm just out there showing our wares and letting people realize that they like it.
Eddie, did we get the addendums on these reports?
I don't think so.
So
Maybe
I
we should
saw
send
the
it somewhere
list.
else.
I did get that list from you, and I went back and looked at it. And the majority of those, like for instance, axillary nodes, we're not going to give a local. I mean, axillary is all you're going to get on a localization. If they're a benign finding, we can do that. The problem is it can become overwhelming because there's so many benign findings that it's like, okay, do you? I mean, if they're relevant, because I looked at these, and for the most part, the only one, let's see, I think I looked at one of Sandra's, and I think she made it a BI-RADS 0. Sometimes what'll happen is that she'll make it a BI-RADS 0 based on the clinical indication or the clinical situation. So she might say this is negative, but recall for such and such an indication. That may have been something we're following that she saw in their previous studies. And so it's like, is that right? I mean, that's one of the kind of the stickier points on mammo. I like to BI-RADS it based on the findings, but I will put in there somewhere, but recommend such and such for such and such an issue. Some will say BI-RADS 0 because the workup is not complete until you've answered the clinical question. So that's more of a fine detail. But I looked at these, and with regards to addendums, I think on Iconopedia, because I've not seen the final product that y'all see, what I see, all right, yeah, I guess we'll take a look at it. But like I said, these, because most of these look like they were kosher, I would say, but we'll keep a tab on it. I mean, that's definitely something, because also I like to know, we like to keep up the, I mean, even though it's not required, I'm applying MQSA. So I want to know, how we're doing on all the numbers. I mean, to me, the two numbers that are the most significant are the NPV and the PPV3, which we don't have PPV3 yet, which is, how many positive biopsies do you get? Because, when people talk about the harms of screening mammogram, that's the number they're really looking at. It's like how many women walk in, go out, get lunch with their friend, and end up getting a biopsy for a fibroadenoma. I mean, that's like, that's so we've got to do better at that, but nobody right now, as far as I'm aware, is focusing on that. And there's some things that we're evaluating to maybe help that. But yeah, so that's the kind of stuff I like to be able to track. I think that's going to be helpful, because if and when MQSA comes in and says, hey, let's show me the numbers, we can say right here, we're ready for you. We are so ready for you.
I get so you don't think we need addendums for these ones? I just wanted to make sure that we completed that.
Yeah, I mean, if you absolutely need an addendum, we're happy to do it. If you could give me the ones, but what I got was a full list. Okay.
So are you saying, like, if there's a benign appearing calcification, the location doesn't matter?
Right. I mean, we can put it in there if
Is
you
that what you
like.
mean?
Yeah, I mean, it's one of those
Okay.
things where that's a plus minus, because we see so many benign calcifications. Sometimes it's diffuse, then we won't give it. If it's something that is clearly benign, if it's in the skin, the Iconopedia should have in the skin, but that's about the extent of it, because so if I can put this the right way. I mean, it's helpful for me, but not as helpful for you. And that is, next year, if I see it, it's helpful if I see in the report, yeah, they were there, no problem. But it's benign. And so benign calcifications shouldn't change. So then it'll help to know if you've got something new. But if you have something new, we're going to know it anyway. And that's what gets the localizing information. If that kind
Okay,
of makes
because
sense.
we're just thinking, like, if a different radiologist sees the same patient in a year, does it matter if, there's findings that were there the year before? Because one of them just said, right, benign appearing
Right.
area, and it wasn't specifically saying a calcification. And so I don't know, we're just used to seeing, like, location for any findings. But if you're saying that you guys typically wouldn't include locations if it's benign, then that's fine too. We just wanted to make sure that those were reviewed and that was intentionally how it was meant to be on your report.
Yes, yeah. For benigns, we don't. I mean, that's like I said, it's a kind of our standard. I mean, it's one of those things where I think, yeah, it's. I don't know if it's a training thing or an age thing, whatever. But I mean, I think once you pass, my magic age, then it's like, okay, look, I'm going to tell you what's important. The stuff that is benign. I mean, we can. It's not anything that. I mean, it's easy to do on Iconopedia. It's just it makes the report so onerous and so overwhelmingly long that you don't really go to the significant findings. And so what we try to do is give the relevant, pertinent information, pertinent negatives as well, but pertinent information, so that way look, this is something you need to pay attention to. Because what I found is a lot of times, if it's so overwhelming, if the reports, I've seen reports that are like dissertations, that it gets to the point, it's like, okay, I'm not sure what I'm looking at anymore. And so the radiologist that follows almost goes back and has to restart the whole process to figure out what exactly they're doing. So that's kind of the fine balancing act, is, put in pertinent stuff, positives and negatives. Don't overwhelm with the stuff that's really not relevant. Like if I see a mass that's been there for the last 15 years, I may or may not comment on it because it hasn't changed. We know it's benign. But, it's one of those things, sometimes the ladies will come in and they'll say, I want you to comment on that. I will respect that. I'll comment on it. Not a problem. It's easy to do. So, if you want us to tailor the reports a certain way, we're happy to do that. I'll pass it on to my radiologist and we'll accommodate in any way, but I just don't want to overwhelm you with irrelevant information.
Thank you, guys. Have a great day.
Thank you.
All right.
Have fun, y'all. Thanks.
Thanks, Dr. Bodne.
You're welcome.